Assalamu alaikum. Thank you, Mr. Chairman. Thank you, dear friend. Yes, in this talk, I'll be talking about Ramadan fasting in individuals with diabetic retinopathy, if, an area that was not addressed in the past. I'll be talking about diabetic retinopathy in general. We'll talk about that it's not addressed earlier. So the study aim was to evaluate fasting safety and glycemic outcomes in individuals with diabetic retinopathy versus those who do not have diabetic retinopathy. The design for this study was a retrospective cohort using, as you heard yesterday, many studies came from this Ramadan UK PDS led by Dr. Hassanin, using our global survey from 2020 to 2022, and it covered all these areas around the world. Now, participants, there were 12,529 patients type 2 diabetes. Group 1 included 1,700 patients who had diabetic retinopathy, and the rest did not. Data was collected through a post-Ramadan structure interviews, as many of the studies that use the data from the DAR surveys. Now, analysis, again, very important that the data was adjusted for age, sex, A1C, diabetes duration, and insulin use in these patients. So yes, I mean, these are very important factors, but we adjusted for them. So let me go through the results very fast. And these are the baseline characteristics for patients with diabetic retinopathy versus the control group. The age was older, as you might imagine. The duration of diabetes was longer, 15 versus 9 years. A1C was higher in that group, a little higher, not significant. Insulin use was clearly higher in the diabetic retinopathy group. And comorbidities, hypertension, nephropathy, and neuropathy were all more frequent in the diabetic retinopathy group. Probably this is a repeat of the previous slide, some of it actually, but you could see clearly that the retinopathy cohort had more hypertension, more hyperlipidemia, more neuropathy, microalbuminuria, CKD, microvascular disease, and even diabetic foot disease. All of them were significantly higher in the diabetic retinopathy group. So let's talk about fasting patterns in these two groups. The prevalence of fasting was lower in the diabetic retinopathy group, significantly so, 71% versus 88% of the patients who did not have retinopathy. Fasting duration was similar for those who fasted, and after adjustment for all confounders, clearly diabetic retinopathy was associated with a 45% lower likelihood of fasting. And the odds ratio is 55. Hypoglycemia outcomes in the groups, we had similar daytime hypoglycemia, 16% versus 15% in both groups. However, there was an increased risk of breaking the fast due to hypoglycemia. So similar hypoglycemia, but breaking the fast due to hypoglycemia was higher in the diabetic retinopathy group. And also, hypoglycemia needing medical assistance and ER visits was higher in the diabetic retinopathy group, and the odds ratio was 1.7. Hyperglycemia outcomes were also similar, 25% in the diabetic retinopathy versus only 13% in the control group, significant, and the odds ratio for hyperglycemia was 1.5. Longer duration of hyperglycemia of more than 8 days was more frequent in the diabetic retinopathy group, 33% versus 22%. And there was no difference and interruption of the fasting, not like in the hypoglycemia evaluation. Now, this is a repetition, and here you could see that the odds ratio of hypoglycemia and hyperglycemia all were higher in the group that had retinopathy. Just a few slides for the discussion. And again, it looks like diabetic retinopathy from the baseline characteristics is a group that was at higher risk to start with. They had hypertension, nephropathy, neuropathy, and even microvascular disorders more frequently. And probably, as we all consider our patients like that, diabetic retinopathy probably serves as a clinical marker for accumulated metabolic risk. Burden probably is a better word for that. So there is a burden on these patients. Now, the second point that these patients have a higher risk metabolic phenotype. And again, even after adjustment for all factors that we consider important, it's clearly there is confounding risk after adjustment. And factors like autonomic neuropathy and some frailty and nephropathy were not actually captured. So there are many possible confounders that were not even captured in this. And again, diabetic retinopathy is a powerful surrogate marker for systemic vascular compromise and higher fast and vulnerability. Now, third point, that observed risk may be underestimated actually. Again, many of these patients did not even fast. So they opted not to fast without even medical advice. And it could be that there is a self-selection for patients who believe that they're at a higher risk. They choose not to fast, which is the healthy faster effect. And probably that will also create a bias and maybe lowering the complication rates, even falsely higher risk. Real world risk in the full diabetic retinopathy population, it could be underestimated here. Clinical implications of these findings should emphasize the patient dialogue and shared decision making, use structured education, CGM, individualized medication plan, and diabetic retinopathy should be actually integrated in the pre-Ramadan risk assessment. As you heard yesterday, now it will be included actually. Limitations of the study are probably clear to all the audience. Possible selection bias, self-reported events, retinopathy grading was not standardized, different physicians and different evaluation, not standardized follow-up. The level, the class of retinopathy was not even mentioned in some notes. And there are so many other under-measured confounders, recall bias and no CGM data. So you could see there are so many limitations that we acknowledge there. However, I mean, clearly diabetic retinopathy patients have, even after adjustment, they have decreased fasting rates to start with, and they have increased risk of hypoglycemia, hyperglycemia, and medical visits for hypoglycemia and hyperglycemia. I would say diabetic retinopathy acts as a clinical marker for advanced disease rather than a direct cause, probably. So we're not claiming it's a direct cause, although it looks like, but again, it's probably a marker for that. And we should integrate the diabetic retinopathy in the Ramadan risk calculator, as you heard yesterday, and that will get a point in the updated risk calculator. And this is the paper. I'd like to thank all my colleagues in this paper. Dr. Ala Atwan, ophthalmologist, was a part of the team, and the rest of the team, many of them are here. Thank you very much. Assalamu alaikum.
Thank you so much.